Good morning. Thank you all very much for joining. I'm Kevin Mathews, and I head up marketing at Elucid. And I have the distinct pleasure this morning of moderating a panel with two physicians who feel very passionately about the topics we're going to be talking about. It's my pleasure to introduce first Dr. Amir Ahmadi, who is the Clinical Associate Professor of Medicine at the Icahn School of Medicine at Mount Sinai in New York. He is the Director of Inpatient Cardiology and Co-Director of the Cardiac ICU at Mount Sinai Morningside. And I'm also joined by Dr. Mark Berlacher, who is the Director of Cardiac CT at the Christ Hospital Heart and Vascular Institute in Cincinnati. Mark has done dozens of Elucid analyses for his patients, and he's going to speak later in the session about the real-world implications of the data he's observed in the Elucid analysis. So with that, I will turn the floor over to Dr. Ahmadi to kick us off.
Thank you very much, Kevin, and thank you, everyone, for joining us on this very early morning of the first day of the conference. It's truly a pleasure and honor to be here and for me to have the opportunity to share some of my thoughts and some of the vision of Elucid going forward in the next few years. I'm also particularly honored here that my mentor, Jonathan Leipzig, is here, and it's great to go full circle. Some of the concepts that I learned from him years ago now, I'm having the pleasure to give a talk about, and he's in the room. So for me, it's very personal and interesting. Thank you. Starting with a case that I saw last Thursday in CCU at Mount Sinai. The picture is not real, the name is not real, but the case is. So Brian is a 41-year-old man that was previously healthy, no past medical history, no medications. He's married with 3 kids. He works in finance, he's a non-smoker, no drug use. And he has a family history, but not premature, of MI at 75 in his father. Mom just had a paroxysmal AFib, nothing really major. His risk factors are not too bad. He has 104 LDL. For the Canadians in the room, that translate to about 2.3. A1C of 5.3, normotensive. He did have a calcium score at age 39, which was 0. This is back in 2023. And his LPA was 20. He presented with a sudden onset of chest pain on the morning of the admission. And for 1 day, he had shortness of breath and exertion. He had mild ST changes in his inferior leads on the ECG. And for that reason, given that he's a younger guy, we actually sent him to cath lab. This is what we found: a critical stenosis in the RCA and another critical stenosis in the circumflex in the junction of OM. So the question is this a rare event? And the second question is, could we have prevented this somehow? I think this is a good opener case to discuss what are we really doing as cardiologists, and what is our framework currently that is basically guided by the guidelines that we currently have. Even though we want to sound sophisticated, but in terms of cardiologists working on coronary disease cases, usually as outpatient physicians, we do one of these 5 things. We either reassure people, or we ask them to change their lifestyle, or we start them on medical treatment, or we send them for further testing, or we send them to cath lab. I can't think of a 6th thing that we do. The way that we do it, the first 3 is based on risk factors, and the second 2 is based on symptoms. The reason that we do it is either to prevent MI or to improve their quality of life. So if we look at this super simplified but yet accurate model that we practice, the gateway that we have to get to treating or screening for coronary disease is based on risk factor or symptoms. So the question is, are these reliable? And we asked that question in our institution by looking at 300 cases, consecutive cases, that came with their first MI, and they were below age of 65. The question that we asked was that if I saw these people as a guideline practicing cardiologist 2 days prior to their MI, how many of them would I have picked at least to give statins, or would I be triggered based on this story to do some form of imaging test as recommended by guidelines? And what we found was appalling, that in terms of the statin indication, 47% of these people that only in 48 hours after that hypothetical visit would have an MI would not have statin indication. In terms of chest pain, 62% did not have any chest pain whatsoever 2 days prior to their MI. 54%, the first ever presentation of pain was on the same day of MI. We put these two together, symptoms and low to borderline risk, and even the convergence of these Venn diagrams would miss 32% of people that have MI based on symptoms and risk factor. So the question is why? Why are we getting this wrong all the time? And I think it's a very interesting math question. When we look at what we've learned about risk factors, about ischemia, about symptoms, it's all based on studies that the two groups that are compared are usually the same size. So when we look at 1,000 people with risk factor, high risk, compared to 1,000 people with low risk, obviously the high risk group does worse. When we look at ischemic people, if it's the equal number, it's the same thing. And symptomatic versus non-symptomatic is the same thing. Problem is, in population, those are not same population. So we have a completely different in size of the denominator of low to high risk, of ischemic to non-ischemic, of symptomatic to non-symptomatic. Meaning that even though these guys, and these guys will cause much smaller rate of MI, it's kind of like a smaller piece of a pie or a much larger pie, that when you look at MI and go backwards, actually, majority of MI come from the low intermediate risk group, people that didn't have ischemia or symptom prior to the presentation. And this is what I call an MI paradox. So then what we can do instead in order to be able to prevent heart attacks, in order to prevent MI in a better way? And I think we need to go back to the drawing board and start thinking about our prevention strategies with better understanding of pathophysiology. So this is a review for everyone in this room. Pathophysiology starts with a plaque. It continues with plaque progression in a specific form that the progression happens because of an expansion of a necrotic core, goes to the side, eats away the fibrous cap, makes it thin, makes it exposed in a certain angle to high shear stress or axial plaque forces, and makes it prone to rupture, and the MI happens. If we don't have a plaque to start with, we're not going to have a type 1 MI, pure and simple. So the whole process starts with a plaque, it ends with a plaque rupture. It's all about the plaque. So we need to have a form of a plaque understanding or assessment in our prevention strategy. So this is what we know, that this is the pathophysiology of MI. I don't think there is any dispute in that. But our practice is based on very interesting assumptions. We think that presence of risk factor is necessary to have disease. We think that obstructive disease happens usually before MI and causes symptoms. For this reason, we are really banking on this factor here as well as the symptoms, as if this is a linear, basically, logic. But in reality, the only thing that we know for sure is that there is atherosclerosis that could lead to MI. Whether that atherosclerosis has a one-to-one relation in an individual that we are seeing in our office with presence of risk factor is questionable. Whether that atherosclerosis goes through a symptomatic phase before the first event presentation is also very questionable. So both of these are false assumptions that we are basically basing on entire practice on. So what can we do otherwise? What can we do instead? We can reverse engineer MI. MI happens because of a plaque that was at a risk of rupture or erosion. That plaque was at the risk of rupture or erosion because it progressed. It progressed because it existed first. It existed because of many factors that I don't understand. Some of them are known risk factors, some of them are genetic, some of them are environmental, some of them are inflammation, and some of them are called X, which probably in future they figure it out. The good news, though, is that these risk factors cannot cause MI without going through this process. There is no such a thing as an acute risk factor crisis. If you have all of these risk factors, but you don't have atherosclerosis, you're not going to have a type 1 MI. Simple as that. The other thing is that there is no such a thing as an acute vessel level crisis. MI always happens because of a lesion that misbehaved. Either it's erosion or it's a rupture. So we need to have information about atherosclerosis. We need to have information about each lesion that we are seeing. And that basically brings us opportunities for intervention. The formation or detection of early atherosclerosis for treatment initiation, to check for the progression for potential intensification of treatment. And when we see a plaque that could be at a risk of rupture based on a lesion-based assessment of risk, which is quite complex, which I will talk to you about in terms of the logic of it, may be a potential for revascularization to be proven later with clinical trials. So our current framework of coronary disease needs some updating. Currently, we think that there is acute coronary syndrome and chronic coronary syndrome. And in acute coronary syndrome, we know revascularization is good for MACE benefit. In chronic coronary syndrome, we actually need to have a presence of chest pain, and we don't know if revascularization has any value beyond just the symptom relief and for MI reduction. But there is a big blind spot in this type of a definition of coronary disease. And the blind spot, I'll just say it by bringing a case. A 65-year-old asymptomatic person that happens to have a 70% prox LAD lesion. Where does he belong to? He's not having chest pain. It's not a chronic coronary syndrome. He's not having an MI yet. It's not ACS. So that brings the whole new concept of atherosclerotic coronary disease that through plaque progression, lucky 1/3 will have chest pain prior to the first event of MI, and an unfortunate 2/3, the first presentation is MI. So the question is, can we be smarter about here? And if there is any role for potential revascularization to prevent MI. And if there was a role for potential revascularization, the assessment logically should be based on lesion-based risk estimation. We see the beginning of such shift in literature by looking at the Lancet New Commission on Rethinking Coronary Disease, shifting from ischemia to atheroma. And this is not, to me, just shifting from ischemia to atheroma. It's concept of probably going away from symptom to actually considering atherosclerosis more and more. So I think the paradigm shift has started, that we go from the risk factor symptom-based approach to a plaque comprehensive analysis in a way that we should be starting doing early screening in a cost-effective manner. I'm not saying that it should be with which modality, but we need to find out the most cost-effective manner to look at atherosclerosis in coronary arteries. If people don't have it, we can reassure them, we can look at the risk factors, we can treat them, we can ask them to modify their lifestyle. If they do have it, they need personalized therapy. And that personalized therapy includes both potential for medications and potential for revascularization if trials in future show that there is a benefit in that. So the heart emojis are basically what Elucid is interested in working, and we are currently working in different strategies for early screening, for personalized therapy, for basically the medical part of the personalized therapy, as well as risk determination for potential revascularization, particularly for MI prevention. Such analysis of plaque will actually remove some blindfolds that, for example, there is atherosclerosis in a low to borderline risk population amongst our patients. That, for example, here you see in a low risk less than 5% by ASCVD, about 42% of people have atherosclerosis, and in borderline, about 60%. And when we go back to the principles of just calcium score for atherosclerosis, we see two things. One is that the sensitivity of calcium score for detecting any atherosclerosis, not just necessarily relating to event, but figuring out atherosclerosis in young people below age of 55 is not that great. Definitely not the best thing for people in their 40s. But also, when we start treating based on calcium score, there is no way that we can actually monitor the effect of our treatment down the road. I recently had a patient in my Vancouver practice, about 5 years ago, had a calcium score of 150. I started him on treatment. He's meeting the LDL target. He's on a little bit of aspirin. 5 years later, he had a little bit of a chest pain. We sent him back for a CT scan this time. He has CAD-RADS 2-level disease, and his calcium score now is 565. I don't know what to do with him. I really don't. I don't know if that 565 is all maturation, or is it a neo-atherosclerosis? And the CT scan doesn't help me because I don't know what his CT scan was at the first place. So if we are going to that approach of atherosclerosis-based treatment and strategy, and we are thinking about the long term, it's no longer only about treatment initiation, but the potential for treatment intensification as well. So personalized medical therapy in the perfect world should depend on overall plaque burden a person has, but also on individual plaque characteristics and plaque features, as well as a delta plaque over time. And risk factors are important. But the difference here with use of risk factors is that risk factors are not necessarily used to initiate the therapy, but they are the situs of the therapy. They are the opportunities when you define the disease. Based on the disease, you can actually look at the person's risk factor and say, okay, based on this amount of plaque, what target should I choose? And we don't have yet the clear understanding, evidence-based understanding of such concept. And this is one of the things that we are doing in the near future with our HALT series of study at Elucid. And if you like to know more about it, there are dinner sessions tonight and tomorrow night that you can talk to Kevin and Vivian to sign up for. In order to have a complete picture here, such plaque burden calculation, individual plaque characteristic calculation should be accurate, reproducible, objective, with minimal inter-observer variability and depending on scan condition. And I think this is one of the strong suits of Elucid. So there are two things that they did differently that I think will provide them with a basically upper hand. One is a concept of moving from non-calcified plaque to non-calcified matrix. So what you see here is a histology of a non-calcified lesion that on this side you have a healthy wall and here you have the non-calcified plaque. Here is a corresponding CT scan to the same thing. So you have the healthy matrix or wall and you have the non-calcified plaque. It's very important to not have inter-observer variability between two scans. What happens is that you need to define the border between health and disease. And that definition in current CT scan is quite arbitrary. So instead of trying to say that this is the border and this is the border and 5 years later we actually say something else that can add to an error rate, we took a dose of humility and we say we can't really define this border of disease and health. We call the entire thing NC matrix, which is a non-calcified plaque with the healthy wall together. So why is this important? Healthy wall doesn't change over time. Plaque does. So any change that you see is not because of inter-observer variability, is actually the change in plaque. And therefore, your delta is more reliable. And when you do the normogram, the first one will fall into normogram anyway. The second part is going from the concept of low attenuation plaque, which is entirely dependent on Hounsfield unit, to concept of LRNC, which is not independent of Hounsfield unit, but take into account the training from histology slides and training that involved a lot of histology samples and cross-sections that the program learned how to adjust the scan condition based on what it sees in the surrounding tissue. And it shows that when you go back to validation of the same histology sample, it has a high correlation value. So the two together causes us to go to a concept of virtual CT histology that is probably better for personalization of medicine because this part of the curve needs to be accurate. So on this side, we need to have answer on risk factors. And our personalized therapy includes, the strategy for that includes a series of studies, which is beyond the scope of this talk today, that talks about each of these and their basically effect on the overall plaque burden and individual plaque features in a randomized fashion by a 1-year and 2-year scan follow-ups. So again, to learn more about that, you have the opportunity to come to the dinners that we have. On the other hand, personalized therapy may mean precision revascularization for symptoms or MI reduction. And our current revascularization strategy, in my humble opinion, is a little bit outdated. We do have indication for revascularization, setting of symptoms and ACS, and that's guided by either physiology or anatomy. The funny thing is that there's a lot of literature of importance of morphology in MI. We never practiced that yet, with the exception of, well, PREVENT trial, which is questionable. Also, we don't talk about atherosclerosis, heart disease, and MI reduction in revascularization. And the funny thing is that I think these two things may be parallel and related. So I think there is some avenue to explore there. So if we go, again, with coronary artery disease paradigm, and we think about the atherosclerosis paradigm, the potential for revascularization could be on lesion-based risk estimation, which I want to talk about a little bit more. So basically, what we've done over the last few years is that, in 60s and 70s, we learned from going from patient to population by looking at the clinical risk factors. In the last few years, we learned that the overall vascular risk by overall plaque burden, where it's quantification of plaque or calcium score, is going to help with patients. We're going to have upcoming trials about this to show if it has benefit or not and it changes outcomes. But also, I think individual lesion assessment could help with the overall picture by adding the information to the overall plaque burden and clinical risk factor in further personalizing treatment. And so the next few minutes of the talk is going to be on the lesion level risk assessment. That's a concept that I think is the modern way of saying what is a high-risk plaque. And I wanted to go above and beyond the notion of HRP positive, HRP negative in a binary fashion to the more actionable form. So conceptually, if you're thinking about high-risk plaque or plaque in general, as people who read CT, whichever plaque that you see fills into some part of this spectrum that on one side you have superstability and the other side you have MI. Anything that we see is somewhere here. When, as physicians, we start medical therapy, we want to push the plaque to this side. If we don't do medical therapy, the natural progression wants to push the plaque to this side. So there's a conceptual timeline for stabilization. We call it T2S. There's a conceptual timeline for event if we don't treat. We call it T2E. Conceptually, if the T2S is shorter than T2E, your medical therapy is safe. If your T2E is shorter than T2S, medical therapy is not safe. You're going to have an MI. So maybe there is a role for revascularization. So how can we define this? We have a lot of information now. We have information about this high-risk issue that is at a lesion level, that is quantitative, that is not just plus or minus. We can actually quantify the LRNC, and it's dynamic. So we need to look at it over time. And it's truly a marriage between lesion-level physiology and morphology. So the components for risk is not just the overall plaque burden and type, but the QCA calcification, LRNC size. If we can measure with the use of AI the distance between the LRNC and the lumen, the delta FFR, PPG, or wall shear stress, as well as the plaque change over time. So basically, what we think is happening for better determination of risk is to bringing in the different factors that so far we created separate lanes for them, and there were constant debates over time in FSCCT that which one of these are more important, and bring them together. And for each lesion, try to decide that risk based on all the features of stenosis, lesion level physiology, and lesion level morphology. We've seen a small example of this in a collaboration that I had the opportunity to do with Dr. Motoyama and Dr. Narula. And we saw that when we look at FFR and we look at high-risk plaque features and we go to this 2x2 table, the benefit from revascularization happens only if you have both FFR positivity as well as presence of high-risk plaque features. You're not going to have it in FFR positivity with HRP negative. You're not going to have it if you had HRP positive but not the FFR. So the star needed to align, and it makes perfect sense from the pathophysiological standpoint that you need to have a plaque that is vulnerable to rupture, but you need to have the forces applied to the right or wrong side of the plaque to basically cause the rupture. And therefore, when we think about the concept of T2S and T2E and the spectrum of risk, and we look at everything that currently could be available to us by a CT scan, we can be able to, again, use AI with prospective studies and figure out a risk on a per lesion level that could be added on top of the overall plaque burden to provide not just a risk, not just saying that this person is high risk or low risk, but to be able to provide some sort of an action item for individual part of that risk. To me, just saying that somebody is a high risk or low risk is not enough. You need to be able to say, you need aggressive medical therapy, but that mid-LAD lesion aggressive medical therapy may not be enough. And this is the reason for it. So in order to understand that better, we designed a preview study, which basically we are looking at 170 patients that happen to have MI and had CT scan 3 years prior to that, or up to 3 years prior to that. They have to have medical therapy. The MI should be determined by angiography, and there should be basically identification of a culprit lesion, compared to 510 patients with CT scan on medical therapy without an MI. What we're going to do is that we take it at a lesion level. There will be a total of about 2,500 to 4,000 lesions. And we're going to blind ourselves what is culprit, what is not. And we're going to look at all of these factors based on Elucid analysis and look to see the predictability of culprit and come up with a scoring system of when we look at a lesion, what is the risk of that lesion. So overall, when we think about the paradigm shift of coronary disease, there is a part for screening. There is a part for plaque quantification and guidance for medical therapy. There is a part that FFRCT becomes important. And there is a part that we can potentially guide revascularization. And in dealing with atherosclerosis, we saw that the detection of plaque alerts, the details of it can predict, and the knowledge guides. And we like to do that on all the aspects of it at Elucid. So I will stop now. My job was to provide an overall theoretical framework for the type of work that we are doing. Dr. Berlacher here is going to showcase some examples of what this feels in real life and go through the software as how the different aspects of morphology and physiology can literally marry together to provide us with a better understanding of patient disease. Thank you very much.
Good morning, everyone. Thanks for coming. Kevin, thanks for the introduction. Amir, that was terrific. It's a hard act to follow, but I'm going to try here. So by way of introduction, I'm a clinical cardiologist. I spend about 20% of my time as a cardiac imager, and I serve as our institution's director of cardiac CT. Most of my time I spend providing direct patient care, and a significant subset of that is spent in our preventive cardiology clinics. So this topic of plaque characterization is of keen interest to me, as I can imagine it is to many of you. I importantly have no financial disclosures today. I don't work for Elucid or any of the other vendors that you will see here over the next 3 days. And I'll be very honest with you, I was a skeptic of plaque characterization when I first started to familiarize myself with this technology several years ago. What I will tell you is that I've changed my tune, I wouldn't be up here, but in using it in the real world, I truly believe that this technology has incredible value, as Amir was alluding to, in terms of individualizing patient care and really in identifying, at least in my experience, in identifying those primary prevention patients that really are much higher risk than the traditional primary prevention patients that really we should be thinking of counseling and managing in more of a high-risk secondary prevention fashion. So I have 4 cases for you today. We should have plenty of time to get through and leave time for questions. So I've skipped the clinical vignette just to save some time, but essentially this is a 52-year-old woman who presented with atypical chest pain. And so she was referred for coronary CTA. She was found to have CADRADS1 disease due to this proximal, can you see my cursor? Yeah, proximal LAD plaque. You can see that there are features of positive remodeling. There are no other high-risk features by traditional CADRADS classification. And so this is a great case to demonstrate the value of plaque for a few reasons. And I'm going to echo the points that Amir had made earlier as we go through all of these cases in emphasizing basically three things: the morphology, so the makeup of the plaque, the anatomic location, of course, and then physiology. So we will look at some plaque-derived FFRCT. So if we turn on plaque, for those that are not familiar or have not looked at this before, basically what you will see is you will get a summary table, and it will tell you the makeup and the quantity of plaque according to each coronary. And so you can see that for her, if you look at her LAD, clearly all of the plaque is in the proximal LAD, right? So it is listed here in the LAD, but really this is the lesion, right? So you have 92 cubic millimeters of non-calcified matrix, and you have 23 of lipid-rich necrotic core. That is a huge portion of lipid-rich necrotic core. And so morphologically, this is a very high-risk plaque. Anatomically, obviously, it's in the proximal LAD. It's prior to this large diagonal branch, and it is supplying a large myocardial territory. So right off the bat, you have a high-risk plaque, and you have a high-risk location. Physiologically, so this is plaque-derived FSRCT. I am told to state that this is not yet commercially available, of course, but we are in the process of FDA approval and that it may be available soon. The neat thing here that I think is that you can actually view not just the FFRCT and these pretty colors that, as you can see, as you traverse down the vessel, you have color change that indicates a change in the gradient, but that you can view FFRCT right next to your plaque. So you can actually see what happens to your gradient as you traverse the plaque. And so if we zoom, we can see while the delta FFRCT is only 0.11 and the FFRCT beyond the plaque is 0.88, may not be necessarily significant by metrics that we typically use, you do have a gradient across the plaque, right? And so this is absolutely someone, you have a high-risk plaque, you have a high-risk location, and you have a gradient across the plaque. While it's not someone that we would need to refer for invasive angiography and PCI, this is somebody that absolutely warrants really aggressive pharmacotherapy, counseling. This isn't a talk on pharmacotherapy today, but this would be LDL less than 55, checking ApoB for residual risk, LPA, CRP, et cetera. And then I would even argue a repeat CT scan in 2 to 3 years to make sure that you have T2S, as you mentioned, T2S, exactly. So that's case one. Case two, very similar. So this is a 60-year-old male who presents with atypical chest pain and is referred for coronary CTA. He also has a proximal LAD lesion that you can see clearly here. The degree of luminal stenosis is more significant, so this is a CADRADS3. And you can see he also has features of positive remodeling and even spotty calcification, right? So this is, by traditional CADRADS, this is a high-risk plaque. What do we glean when we add plaque characterization? Well, we can see, again, most of the plaque is in the proximal LAD, and again, the makeup, if we're looking at the LAD, he has some calcified plaque, but again, a really high proportion of lipid-rich necrotic core, almost 20%. And so again, we have a high-risk plaque at a high-risk anatomic location, and physiologically, if we look, we can see that the gradient happens right where the plaque is, right? So that is a concerning feature. And the delta FFRCT here is 0.16. So while the distal FFR is greater than 0.80, we're getting a delta of 0.16. And many know probably from prior analyses of either the advanced registry or Emerald that 0.12, 0.13 as a delta FFRCT is really one of the best predictors that we have of future events. And so this is a hot plaque, right? This would be something that we would be extremely worried about. And so I think we need more data on what exactly to do with this patient. But I think that many would argue, based on PREVENT or others, that this would be somebody that would be very reasonable actually to refer for cath and PCI. Alternatively, aggressive medical therapy, and I would argue even shorter term follow-up in terms of maybe 1 year repeat CT would be very reasonable, but obviously a concerning finding. Case 3, so slightly different case. So this is a 75-year-old man who presents with chronic, stable, typical chest pain. And he is found to have diffuse calcific atherosclerosis involving all 3 vessels, but severe disease of the mid-LAD that you can see here and here. And what we see when we apply plaque for this patient is that really it's predominantly calcified plaque. He has 0 lipid-rich necrotic core in the area of interest in the LAD. And if we look specifically at the level of the lesion where the severe stenosis occurs, which is here, it's really all calcified plaque, right? So this is not unstable plaque at the level of the lesion. Oh, I'm gonna go back. And sure enough, when we look at our hemodynamics across the lesion, it's happening right next to the calcified plaque, right? So you have a delta FFRCT that confirms his symptoms, but the plaque is calcified. And so this actually would be a patient that I think would be very reasonable to invoke ischemia and to manage medically, particularly if you can control his symptoms with anti-anginal therapy, and if you're happy with where you are in terms of preventive pharmacotherapy and the targets that you're trying to achieve. So you can see the plaque is here, predominantly calcified plaque right at the level of the lesion. Okay, last case. So this is a 72-year-old woman who, again, also has typical stable anginal chest pain, and she is referred for coronary CTA, and she is found to have diffuse calcific and non-calcific atherosclerosis with the LAD being severely diseased in the mid-vessels, so another CAD-RADS 4A. And we can see that when we apply plaque for her, she has mixed atherosclerosis, right? She has calcified plaque, she has non-calcified matrix, and she has some lipid-rich necrotic core. And you can see visually that, unfortunately, the lipid-rich necrotic core for her is occurring right at the level of the lesion that we're most concerned about. So you have a severe stenosis at the mid-LAD, and you have a potentially vulnerable plaque right at that location of lipid-rich necrotic core. And our FFRCT confirms basically you have a translesional gradient of 0.17 that is significant. And so this would be somebody that, in contrast to our last case, that you could argue making a medical management for, this would be somebody that would be very reasonable to refer for invasive angiography and PCI. So that's all I have. I think we should have some time for questions. Yeah,
absolutely. And
thank you.
Thank you very much. So I would certainly thank Dr. Ahmadi and Dr. Berlacher for the very compelling content. We do have a few minutes for Q&A, and you have a few options for that. We've got a microphone here to my right, middle of the room. Also, if you have the FSCCT app, you can enter a question in this session link, and I can relay the questions here. So I would open it up for any questions or comments that have originated from the content this morning.
I think till we are waiting for the questions to come, I just wanted to point out something about these cases that is very interesting. I think the ability to be able to look at the CT, this was an interactive viewer, by the way. Look at the raw CT, look at the segmentation, look at the plaque morphology, and apply FFR on top of that is pretty interesting. And as you saw in these cases presented by Dr. Berlacher, by the knowledge that we get from the information that we have, we can go away from a binary distinction of FFR positive, FFR negative on a 0.8 level to a much more sophisticated, not only translesional FFR gradient, but combination of translesional FFR gradient and a plaque morphology right at that point. So with this approach, we are not talking about plaque assessment as a preventative therapy and FFR assessment as a guide for invasive measurement, but everything together as a truly a marriage of between these components to guide therapy for the patient, which could include medical therapy or revascularization for both MI and symptomatic prevention. Jonathan.
Maybe I'll speak up so my aged legs won't walk all the way over there. First of all, thank you for the great presentation. I completely agree, and I think the presentations, Dr. Berlacher, around translesional pressure loss are so important. As you point out, I think the field has moved away from physiology as a binary tool. Really important. One question for you, Amir, and I think you highlighted the idea of, if I get it correctly, integrating the wall and understanding the wall won't change, sort of tearing the scale, I guess, right? Using that as a baseline. The question I have, though, and it's not unique to Elucid's technology, but we've seen in the Miami Baptist work that was presented at AHA using another vendor that the rate of positivity in a binary, presence or absence of plaque was 94% in males. Obviously this is integrating, I would assume, normal wall. I don't accept that 94% of 52-year-old males have plaque, or even if they do, on some level that the human eye can't identify, that flies in the face of 20 years of visually guided CT management. So how do you get around that issue? Because still, you're right, on the follow-up you can subtract the wall, but if you call the wall abnormal, you have an issue, right?
Right, so great question. And I don't think we are calling the wall abnormal. We are calling the entire thing matrix. In fact, what one of these things, one of this positive effects of this technology does is that it completely takes away the distance between the definition of lumen on one side and definition of wall on the other side. It brings it together. So when you add up the entire distance that they have over the length of the vessel, that volume is going to reduce. So you reduce your quote-unquote phantom plaques that other vendors would potentially give you. So I think that's a very important piece. So it actually tries to solve that issue, the very issue that you're mentioning. Number two, we need normograms. So what I can think, and I've seen all three major vendors, is that this is, at this moment, it's not a apple-to-apple comparison. And I think each vendor has to have a normogram for their own to see what the normal is, what mildly abnormal is, what a little bit more abnormal. So that first instance of what you tell the patient, do you have a little bit of disease or not, needs to be normalized for the vendor. But then after that, the inter-observer variability and objectivity will be there. Theoretically with this technology, we need to prove it though. Great question.
Great, thank you. And we've been getting some questions in the app, and I'll begin to go through these. Maybe I direct this at Dr. Ahmadi, is how accurate are the tracings when used clinically? Do they need adjustment from the user?
You mean the segmentation?
Yeah.
Okay. So like anything else, it's process that will improve over time, and like pretty much anything else with technology, the more forward we go, the more independency of human and dependency on AI technology and refining AI technology. So what I can say is that yes, it is something that it's a work in progress, that we are getting better and better on a daily basis. But I think in 2 or 3 years from now, it's probably going to plateau in terms of its improvement, and it's going to get to a very ideal state.
Perfect, thank you. We've got a question for Dr. Berlacher, is how does a very high-risk plaque with positive FFR guide your exercise and other lifestyle counseling?
If you're not referring those folks and they're truly not symptomatic and they're not going to go for invasive angiography, I think it's just it's a conversation with the patient, right? And it's being basically, as we alluded to earlier, being very aggressive. So the targets that you shoot for in those patients, even though they are, quotes, a primary prevention patients, they really should be more in line with what we're using for our very high-risk secondary prevention population, right? And so, and if you can't find the risk factors, so for example, you have patients that maybe fit that scenario that already have very good LDL goal, they're not a diabetic, they don't smoke cigarettes, you're reaching for some of the other things that Amir put on his slide, right? You're talking about checking a CRP, potentially using colchicine, using antiplatelets, really everything that you can. And if there's not much to move the needle on in terms of risk factor modification, then I think you do talk with them about potentially PCI, right?
Great. Yeah, thank you.
Question in the audience.
Oh, I'm sorry. Yeah.
Hello, Carl, I'm Young from New Zealand. Look, traditionally in the asymptomatic individual, we've relied on a calcium score rather than formal CT angiography. But clearly the case number 1 with a 0 calcium score and a subsequent event highlights the fact that we should challenge how we navigate those particular individuals. I know it's a huge question, but how do we then decide in whom we should be formally investigating rather than just relying on a calcium score? Thank you.
So I think that's an excellent question. It's very pragmatic and what we are dealing with in our heads pretty much every day. There are 2 potential problems with calcium score. One is that in younger individual, it's not sensitive enough for not just detecting events. Not many events will happen, but detecting atherosclerosis. Why is that important? Because conceptually, we are moving away from guesstimation to figuring out atherosclerosis to guide treatment. So if I want to guide treatment of a 40-year-old man with regards to atherosclerosis for the rest of his life, I need to have a reliable method, sensitive method of detecting that atherosclerosis. I cannot be okay with 70% sensitivity of that case. So that's number 1. But number 2, and I think even more important than number 1, that applies to everyone, we need to have a test that we can retest and we look at our treatment effect. We cannot do that, simply cannot do that with calcium score. And my prediction is that this concept that I just said is going to come more and more in the next 2 or 3 years. Why? Because we are about 10 years out of the revolution of calcium score as one of the things that we do to initiate therapy. So now people are going to start thinking about, okay, so let's redo it. And what they're going to find out is that 150 calcium score went to 500. Now what? Should I intensify my treatment? Should I do an exercise test? Should I send them for a SPECT? Should I send them for CT? If I send them for CT, see a bunch of non-calcified plaque, are they new? Are they old? We don't know. So I'm not saying that everybody needs CT. I think we need to have we may get to that conclusion that everybody needs CT. I'm not saying yay or nay. We need to have a cost-effective analysis, and I would bet on technology. Meaning that there probably is a third option out there that can help us, that is not as expensive and as time-consuming and and is not as crude as this one. And it's kind of like a middle way, and maybe something like that will come and help us. But we need a reliable, sensitive method to detect atherosclerosis.
I don't have anything to add. I would say that I agree with you. We basically need more data. We don't know that information because absolutely there are those patients that are hanging out there that are completely asymptomatic and are just, in some sense, waiting to have their event. And so we need more information. Yeah.
It's great question. And to build on that a bit, we've got another question from the chat. Do you propose that CCTA with Elucid be done in every patient above a certain age for assessment? What will the cost effectiveness be of such approach?
I can take that one, yeah. So I don't think I would propose that it's done in every patient above a certain age. That'd be a lot, and I think the cost effectiveness would probably not be in favor of that necessarily. But I think, of course, in symptomatic patients, and of course we have guidelines for chest pain and workup of symptomatic patients. I think the asymptomatic patients above a certain age or in a certain risk category is really where the question comes, and that's again, as we said before, we just need more information in that population.
Great, thank you. Actually, I can probably take this question. Is this FDA approved for clinical use, and how many sites are using this? So from a Elucid perspective, the plaque composition product that was shown is commercially available since January of this year. We're in multiple sites across the U.S. The FFRCT, as Mark highlighted, is still under development, and we anticipate a submission on that product to the FDA later this year, and then commercial availability very early next year. All right. Any other questions from the audience? All right. Well, thank you both very much for your time, and thank you all for joining us. Enjoy the first day of FSCCT.